Good afternoon, everybody. The next part of the day is going to be a panel discussion. And as Angela said, my name's Sean Morrison, and I'm going to be chairing the session. What I'm going to do is briefly introduce the panelists as we go down, and then first open it up whether there are questions from Dr. Blumenthal's talk. And following that, I'm going to moderate a discussion around healthcare services research and the needs of our populations from, as you'll see, birth through old age. So let me begin with introductions, which are now out of order, given what I had thought, but let me do this. So, let's do it in the order I have so I don't get confused. So first of all, Elizabeth Howell, who is the director of the Blavatnik Family Women's Health Center Research Institute here at Mount Sinai. And Liz's work focuses on the quality of care and ethnic and racial disparities in maternal and child health. Liz is an obstetrician gynecologist by training, and she will introduce her work in much greater detail in a minute. To Liz's left is John Steever, who is a pediatrician and the director of special programs at the Mount Sinai Adolescent Health Center. And his program serves over 10,000 vulnerable adolescents living in New York City. To my immediate left is Nina Bickell, who is an internist and the director of the Center to Achieve and Sustain Improved Health, and the co-director of our Center for Health Equity and Community Engaged Research. And Nina's work focuses on assessing and reducing disparities in breast, ovarian, and prostate cancer treatment. Hear the theme? And then finally, to Nina's left is Nathan Goldstein, who is a professor in our department, Geriatrics and Palliative Medicine, and our site chair for Geriatrics and Palliative Medicine at Mount Sinai Beth Israel and Mount Sinai Downtown. Nate is a true product of Mount Sinai, having done his medical school residency, fellowship, and all of his real-life work here, although we went him to Yale for a year to do his RWJ Clinical Scholars Program. Nathan's work focuses on improving physician-patient communication in the setting of serious illness and on developing models of care for high-need, high-cost patients. I agree with Dr. Blumenthal. We have a lot of models out there, but we still need a few more in the microsystems, and Nathan is working on developing those. So those are the new faces on the panel.
Should we really confuse everyone and now organize ourselves by where we take care of patients in the lifespan?
Well, that was what I was supposed to happen up here, so it really threw me when the names were all mixed up. And I think, Angela, you introduced Kelly Kelleher at the end there? Yep. Right. So let me just start if there are questions from the audience or from the panel to Dr. Blumenthal. And we have mics in the aisle. Dr. Friedman.
Dr. Blumenthal, it seems like it should be so simple, and yet embracing these principles seem to be very scattershot. And I'm wondering, what are the real incentives? Because it strikes me that academic health centers invest in infrastructure, information systems, which you're very familiar with. All of that costs money, and socializing your staff and faculty and patients. So what's the incentive to undo those kinds of infrastructure efforts and adapt something even if it makes perfect sense?
Well, there's no incentive as long as you're paid fee for service. We were visited at the Commonwealth Fund because we give away money. People come see us. And we were visited by a program, actually a pediatric program, that purported to care for very sick children in a very, very cost-efficient way. And I won't tell you what program it is, but it's a very respected provider of services. And they wanted help to implement this program, but their health system was not providing the help. And it was very clear why they weren't, because there was no return on that investment. They would just continue to have to put money into it indefinitely and lose money from the services that would be foregone because they were avoided. So that's why we've made it so hard to do the right thing. You do see, once the incentives are reversed and once organizations are accountable for or have an opportunity to avoid loss or improve profit from containing expenditures and improving quality, you do see some pretty dramatic changes in behavior. It may not happen all at once. There are certainly blocks that have to be circumvented. But it does change, it begins the process. It opens up for, and then I think creativity becomes, we're a very creative group of people, all these clinicians and administrators. We can do new things, but we are not going to do them if we cut our throats in the process. Just doesn't make sense.
And what's a prospect from government either imposing or incentivizing a shift to population health management, for example?
Well, what population health management is the ultimate goal. You can stop short of that by just saying, I'm going to accept responsibility for the clinical services for a given period of time, for a year, or generally for a year, makes the most sense. So then you begin to see opportunities to change what you invest in, to look at those services not for what you can get billing them for billing, but what you can get back in terms of foregone expenditures. And there is an absolute explosion of investor-owned, for-profit Medicare Advantage plans taking place around the country right now because they see huge opportunities for net revenue by accepting an annual payment for Medicare patients and then trying to find ways to avoid hospitalization or treat things at home that were being treated in the hospital.
Right.
So there is a financial opportunity that the market is showing very clearly is available. I think that big institutions are slower at realizing that and investing in it.
Thank you.
Yeah, yes, Dr. Bickell whispers to me, can I ask a question? Yes, you may.
So I was particularly intrigued by the examples that you gave of various kinds of community connections that have been tested out as innovations to improve particularly primary care. I'm assuming the lift was from some of the stuff from Penn. But what I'm wondering about is the issue of sustainability, and because most of those were grant funded, at least initially. And so moving forward, particularly in this climate where it's unclear that Medicaid will continue with the disparate connections with community, of really how can we sustain and grow these kinds of connections and support different kinds of organizations that are providing these necessary services?
Well, in most of the world, we sustain them through collective contributions that are funneled through government. That's not an option in the United States. So we have to have alliances with the private sector in which the systems are organized so the private sector sees a return. And all the programs that I mentioned are capable of self-sufficiency and of saving money. CareMore is part of a huge for-profit organization and is spreading rapidly. PACE is less clearly profitable, but it probably does save money. And the Medicare Advantage plans that are, and CareMore, by the way, invest in Lyft because it saves money. So you've got to internalize these savings, and that makes the programs sustainable. And in the United States, because we won't invest in these things because they're the right thing to do, we have to make them, somewhat regrettably, we have to make them the profitable thing to do.
Let me move down to the far end because I believe Dr. Keller had a question, and then is somebody standing there? I'm sorry, I'm looking right into a
sorry,
spotlight.
of course,
Sorry
yeah.
about that. So let me go down to the end of the panel, and then we'll go up there to the shadow that I see.
Yeah, actually, I just want to make a comment that it's not on the scale of Medicare, but Medicaid for children actually is already endorsed. There are now 9 states that have ACOs, and those that are at risk for children's care can actually innovate in a lot of these ways and save the resources. So, for example, we have a $1 billion contract in 34 counties in central and southeast Ohio, and the surgeons, after we were capitated and fully at risk, said there are many ways we could save money. And we just haven't been able to do them now because you pay us by the number of surgeries we do. But they came and they have reduced, for example, appendectomy surgeries by 1/3 by using non-operative management in the early stage appendicitis for children. And they've reduced the number of scans they've done and switched to ultrasound. And they've reduced, they do single visit care for rural children because they no longer need to do a pre-visit, a regular surgical visit, and a post-visit. So physicians find ways to respond to the incentives we give them. And on the Medicaid level for children, there are many ways to do that. And our ACO is now 15 years old and has shown savings every year.
Yeah, I would just like to add that Medicaid is another example of the adoption of at-risk payment that is going well, it's spreading rapidly. I don't want to comment on whether it's going well or badly, but a number of the most successful insurance plans now are Medicaid plans or once were Medicaid plans and have expanded to take care of non-Medicaid patients. And they're very good at managing costs because they had to do so under the fee-for-service system.
Let me go to the mic up there, and could you introduce yourself before your question?
Sure, Andrew Kasarskas in the genetics department. So this is a question, I guess, motivated by Dr. Blumenthal's talk, but really I'd be interested in hearing from the entire panel or whoever would like to address it. So speaking of high-need, high-cost patients and how to care for them is one aspect of things, but I'm also interested in the question of how one might actually prevent the development of high-need, high-cost patients. Obviously, if being old and approaching the end of life is a major risk factor, that will happen eventually for everybody, but I suspect there are things that could be done effectively. And you sort of touched on that a little bit with the relative spend of dollars on medical care versus social services, but if you maybe there's some way to elaborate on how that fits across the lifespan, that'd be interesting to hear.
David, you want to start, and then I will go down?
I'm going to turn the mic over to my pediatric colleagues on the panel because one of the absolutely most important thing we can do is invest in health care and services for children. There are now very good studies that show that eligibility for Medicaid or use of Medicaid services as childhood is associated with higher income levels and better school performance later in life. So those are long-term investments, the avoidance of childhood trauma. It's not my area of expertise, but it certainly would be a great investment. Prevention in general is not often as cost-effective as it is thought to be. It's the right thing to do because it avoids suffering, but it doesn't always make money as it is commonly thought. So, but there are things that clearly are cost-effective, like vaccination, and also the prevention of chronic illness by treating hypertension if we treated every hypertensive in the United States, that would probably be the most effective public health intervention that we could take on right now.
So I'm going to ask Liz first and then John to respond to that, if that's okay with you guys, and then the rest fill in after that. Liz, you're up.
Sure. So, as a person who's an obstetrician, I think about the care continuum and access for women to health care across the entire spectrum. So from throughout our reproductive lives, access to safe and reliable contraception, preconception, so that women who have chronic illness, their health can be optimized, and all women can health can be optimized. I think about it in the antepartum and delivery care period as well as postpartum and interpregnancy care. So this idea about prevention in women's health, and what I particularly study is maternal mortality and disparities, and I think many of you have probably heard a lot about that in the news recently. Our rates are very high. We have significant racial and ethnic disparities. We have significant severe complications for women in pregnancy, and this is all related to these rising trends of obesity and chronic illness, lack of access to appropriate care. And we fail women because we fail women in a lot of aspects, but one of the things is around postpartum care. So when we were talking about Medicaid earlier, pregnant women get Medicaid services who are up to the 133% of the poverty level. It's up to 200% in some states. ACA expanded this. But women don't get care postpartum, so they only have coverage up to 60 days. Well, we have a lot of ill patients who are pregnant these days. These are the women who have severe complications during delivery. These are the same women who have gestational diabetes, which puts them at risk for type 2 diabetes. These are women who have hypertension and preeclampsia during pregnancy, puts them at risk for cardiovascular disease later in life, also puts their next pregnancy at a much higher risk as well. And so I think that access to care is something that we really need to start thinking about and focusing on, and it can improve not just for the pediatrics, but before that for women's health.
John?
I agree. I mean, as somebody who works with primarily adolescents, kids, I mean, obviously some of the things that I see, I'm not going to be able to fix because honestly it should have been started and worked on when the child was much younger. So pediatric obesity, by the time they're teenagers, it's hard to start to bend that curve. But having said that, I still think there are many things that I can do that are preventative. You mentioned reliable birth control. And so to try and provide a clinic and a system that provides, quality birth control that's free without barriers. I know the math has been done. I remember working at Kaiser Permanente in California years ago, and they came to the conclusion that if you really reduced those barriers to birth control, that it actually made money for the healthcare system. So there's a lot of preventative things. I do a lot of work with trying to encourage people to stay in school and complete their high school education, because we know that breaking that helps break some of the cycle of poverty, which is part of their long-term stuff. Some of it I don't know if I can quantify, but certainly with things like birth control and access to care is important. Vaccines. I always tell my residents that I work with, even if somebody has just walked in for name it, an ankle injury or a cough or something, well, what's their vaccine record like? Because I can use that opportunity to try and prevent future illness. So really decreasing, I think, some barriers to primary care and using every visit as a way of reinforcing some of these things is kind of how I look at it.
Anybody else want to tackle that? Kelly, I see you leaning forward.
Oh,
Please. This is why you're here.
It's, I just think we're forgetting, if everything comes out of the healthcare system, that the largest discrepancies in health outcomes in communities are based on neighborhood. And so the neighborhood a child is born into is the neighborhood that predicts the adult health status, adult economic performance, and subsequent chronic care issues for those adults. And so we really need to look at the neighborhoods in our communities that are driving our disparate health outcomes, in my opinion.
Nate.
Yeah, so, and then I think when we think about it from the other end of the perspective, from a geriatrics perspective, we have to think about sort of all the geriatric syndromes and sort of once they have these chronic illnesses, how do we support them with social support at home so they can do the things we want them to do. So, one of my favorite examples is we can give folks the absolute right antihypertensive, but if they can't open the bottle because they have arthritis or they have macular degeneration, so they can't read the bottle or they can't remember to take the medicine, or because they also have an enlarged prostate and dizziness, and when we give them the 3 different medicines to treat each of these, their blood pressure drops to the point where they're always fainting and falling and having fractures. We begin to think about how do we think about these folks in a holistic way and put social support within the community to keep them at home. One of the things that we're doing from a palliative care perspective is creating a model of community or home-based palliative care, and we think it's innovative for a lot of reasons, but one of the things that we think is most innovative about it is the frontline team is not a doctor. It's a nurse, a social worker, and a community health worker, and what we're most excited about as a community health worker, which traditionally has been sort of a disease-based specialist. So the classic example of a community health worker is the patient with diabetes, someone who takes them to the bodega to explain to them which foods they should be eating, which foods they shouldn't. In this case, we're using community health workers to teach them about their illness and misconceptions about palliative care and misconceptions about the medications that we use to try and improve disease understanding and help their caregivers get connected within the community. So we have a patient right now with Alzheimer's disease, and one of the things our community health workers have done is to hook the caregiver up with some of the resources in the community for folks with dementia that has helped the caregiver reduce caregiver burden and kept that patient at home. And so while we're obviously treating the medical issues and the symptoms of that patient, at the same time, our model is helping the caregiver get connected with resources, with social support, sort of thinking about Elizabeth Bradley's work, with the social support they need to keep them in the community in a different way than sort of what we traditionally think about in terms of providing health care.
Angela.
I just want to add that something that often we don't think about is the high level of trauma in the life of children, adolescents, and adults. The population that I work with, I'm seeing them when they are teenagers. They have 23% of them have a history of childhood sexual abuse. And when you layer other type of abuse and trauma and community violence, racism, if there are people, youth of color, teen dating rape, the community, the stranger rape, by the time I'm seeing them as teenagers, like 50% of them have a history of sexual violence and other type of trauma. And I think that I can check all the years that I want, but unless I really take that history and try to identify those young people and then provide specific trauma intervention to help them heal, they are not going to do as well. And with the right intervention at the right time, you can deal with the level of stress that they have, the substance use. They are more likely to stay in school and things like that. So that's another issue that often we don't think about.
Thank you very much.
Thank you. The next shadow. Sorry. Go ahead.
Oh, no. Hi, Madeline Gray. I'm from the St. Luke's Department of Psychiatry. And I was wondering, this conversation has largely skirted psychiatry and behavioral health, and these substance use and behavioral health, especially the comorbid populations, are responsible for huge amounts of the cost and also are the hardest to engage in long-term treatment, and, are largely, all of these behaviors exacerbate all the other issues that you folks deal with. And I was just wondering, how you all consider the role of substance use and psychiatric crises or conditions within the caring for the community for the lifespan, and how you view taking social work and de-siloing it from the pointy end and bringing it back to the blunt end instead of using it on a more ad hoc basis. Thank you.
Volunteers? John's stepping forward.
I will certainly say for my clinic, we really do put mental health and medical stuff together. We have primary care social workers whose offices are not some other floor in our building, but literally embedded within the medical floor. And they are on, we have a walkie-talkie system where we can reach out to other services and they're on that system. And so I can, if I identify somebody with a mental health need in the very broad sense of that word, all I have to do is pick up a walkie-talkie and say, hey, I need help here. And I've got somebody in about 5 minutes. So having that connection is incredible. We share a medical record. I can see what they're writing. They can see what I'm writing. We talk all the time. So that kind of interaction is great. great. We wrote that into our model for our HIV care. And so when I see a patient with HIV, I actually call the social worker, their personal social worker, into the room, and we discuss their health history and what's going on all together. And we find that really effective at helping break down barriers. The other thing is to remember that these kids have trauma. They also are disorganized. They have trouble getting to the clinic. And so to have a model that says, your appointment's at 10 o'clock and it's 10:20, sorry, come back tomorrow, doesn't work for us. And I don't think it works for these kinds of patients. So when I got a kid and I see he's on, I look at the schedule and, oh, okay, I know this person, they smoke a ton of weed, and he's 2 hours late, I'm gonna see that kid, because if I don't, he's gonna go out and do his thing and just not get any care. And so I'd rather squeeze the kid in, do what I need to do at that moment, and be sort of very patient-focused, I guess, is the sort of the answer. So, I think that's one place where when we talk about systems, being really mindful of the person who's getting care and meeting them where they're at is helpful. And I think that is a challenge for a lot of clinics to be that disorganized, because unfortunately that means the rest of my clinic has to suffer a little bit because I'm running late. What a shocker. So.
Yeah.
It's, you're raising a really critical point, and similar to the adolescent and pediatric part, within primary care and adult medicine, there's been that similar kind of push. And so we have integrated behavioral health within primary care. And so not only do we have social workers, but we have internists who are trained specifically with additional training in psychiatry, and we have the psychiatrists there as well. And so we have depression specialists who will come in and have warm handoffs. So there's been particular attention to that. And in terms of the opioid crisis and substance use, again, with that, because there's been such tremendous growth, there's been innovation, and there's a new program that's developed and been implemented to not just train people in the waiting area who are interested in BUP prevention strategies, but also another program that's actually dealing with users to be able to both essentially reduce the use. So there's been tremendous attention to that.
Great.
I will say the easy answer is we are also, we like to think, pretty well integrated. So in our geriatric practice here at Martha Stewart, we have geriatric psychiatry who sort of shares the space with us a couple days a week. In my palliative care practice downtown at Beth Israel, we have addiction psychiatry fellows with us in the practice, seeing the patients with us simultaneously. However, I will say these are by far the most challenging patients. As I say, I do clinic on Wednesday afternoons, and every Wednesday I say, yeah, it turns out there actually is an opioid crisis in our country. I see it every day in clinic, and it's incredibly challenging. And when you add on that, many of our patients have a healthy dose of some form of psychiatric or mental. I like the fact that you sort of said mental illness in the broadest way defined. I don't think we have the right answer. I think many of us are putting it into our research models and the clinical models we're building as well. But you're right, they're some of the most challenging patients.
Go ahead. Thank you so much. Oh, go.
I was just going to add that as an obstetrician, this is a major issue, particularly around postpartum depression and perinatal depression. And so it's something that we work very closely with social work to do screening and to refer patients and do that. But a lot of my research, if I can sort of share on that front, we recently did an RWJ-funded study where we partnered with Health First, which is the largest Medicaid managed care organization that supports deliveries here at Sinai, ourselves and the New York Academy of Medicine, and we had social work on our team, and we constructed an intervention that was through social work and a community health worker targeting high-risk postpartum women who we defined both with clinicals like gestational diabetes and hypertension, but also with positive depression screens to try to get them the right care, give them self-management tools, but then also help them in that period after discharge from the hospital, in that early postpartum period where they're just, on their own so much, and in an effort to try to connect them with the services they needed to bring them back for postpartum care and then to have a smooth handoff. And so that has been a really powerful thing for us, but mental health was one of the key components of that. So I think OB is also here thinking and about this really important issue.
Awesome. Thank you so much.
Question on the right? Yeah.
Yeah, my name is Anand, and I'm part of the psychiatry department here. But the question is slightly around a different aspect of it. What I could understand or see is most of these care today are woven around how the health insurance companies work and the limitations around them. And even a lot of innovations are all kind of not supported in a way. What would be some of the disruption happen in that side of the equation which can actually help to provide a better care in the community?
So one of the things, many of us had dinner last night, and one of the things that we talked about was how we can build some of these questions around sustainability and managed care and moving away from fee for service directly in the research models and the programs we're testing. So, for example, the model of community-based palliative care that we're using has a couple of goals. One of which, the obvious things: keep people out of the hospital, keep their symptoms controlled, keep them in the community, help their caregivers. Those are sort of the very standard health services research outcomes that you would expect us to be looking at. We're also trying to, at the same time, create a model that we can think about savings. So when we move past the research piece to think about implementation and sustainability, we've already built in the metrics and the questions that a insurance partner would want with us. So when we go to them and we can sort of say, look, it worked from a wonky research model, but when we also thought about shared savings, shared risk, if you fund it, the average cost per patient is X. If you pay us Y, we can split the difference Z in that. And so that's sort of a new way of thinking about health services research, I think, which is the traditional outcomes that you look at, but then building in this idea of sustainability. And, I thought Dr. Blumenthal said it well, which is like, you don't really want to talk about it, but you really have to talk about cost in all of these models, because if you prove it works, but you can't keep it sustained and you can't get insurers interested in it, you're kind of dead in the water once the grant funding is over. And so trying to build models from the ground up and from the very beginning, thinking about sustainability, not, oh, it's done now, how am I going to keep it going, but building that into the actual research design.
I would just add to that comment. I'm going to take moderator's privilege. We're in a relatively both unique and challenging environment in the United States because of how healthcare is funded here. And for example, if we were in the UK, we were in Canada, we were somewhere else, and we demonstrated that our intervention improved quality, and we increased longevity, and our qualities were terrific, it's almost a no-brainer to get it moved into the national health system. And that's how we typically think about health services research, is if we can demonstrate, have a grant-funded program, demonstrate that it improves outcomes, it should be natural that it's funded. And that's not the way things work here. And I think that, as Nathan said, the challenge of researchers is not only to think about, can we develop interventions that improve outcomes and maybe cost-effective, and how will they fit within both current and possibly projected reimbursement systems and models? Because if we don't do that, they just sit within our laboratories. And I think as health services researchers, most of us have not done a good job at thinking through that next step. And I still remember a conversation with one of my colleagues who said, that's not my job. My job is to develop the intervention, publish it, and let somebody else pick it up and move it forward. And I don't think that is our response. I think if we're taking publicly funded dollars, for example, from the NIH, our responsibility is to make sure that anything we developed can be implemented within the current health system. Sorry, I'll get off my soapbox. Yes, to the back.
Thank you.
Bas Pollack from Oncological Sciences. I have a general question, but it's actually maybe go to Dr. Blumenthal. You mentioned that the US spends 17% of the GDP on healthcare, and it seems to be the results are not brilliant and not everyone enjoying it. And you suggested maybe that increasing social spending can help. But Canada, for example, from your plot, it seems to be that Canada has the similar social spending like the US, but they still get better results than the US with respect to the healthcare. This is one question. And second, if it's now 17% and not too many people enjoying equally the healthcare benefits in the US, what will happen when we will manage to get to all people in the US and give them similar treatments? It will jump to 30% of the GDP, 40%. So I'm trying to understand how we can lower the cost of the healthcare, because I think it's not necessarily high because we go to all people in the US.
So good questions. First, Canada is actually a relatively poor performer. We rank the overall health system performance. That is, I didn't show any data on that score in this particular talk, but we do that every 3 years. We do a ranking of 11 countries, developed countries. And Canada has declined in its performance over the last several decades and is now the second to the United States in lowest performance. So I wouldn't use them as a model. They're discussed way too often in public policy terms in the United States. We should be talking about the best performers, which are Australia and the Netherlands and the UK, and each with quite different systems, but each with doing much, much better on both health and cost and access dimensions than is Canada, the United States, or most of the other countries you look at. So I don't think I have to explain why Canada does so much better, because they don't. They do, however, have wider access than we have, and that's probably one reason why they do slightly better than we do. We're now actually close to 18% of GDP, and actually this past quarter we had a decline, first time in several decades, we had a decline in the proportion of GDP spent on healthcare. That's largely because of a quarter or two of rapid economic growth rather than declining healthcare expenditures. But healthcare expenditures still grow faster than GDP most of the time. The way most of the world contains healthcare expenses is by containing prices, reducing prices. Prices are the problem in the United States. That is what Mount Sinai and Cornell and Mass General and UCLA and all these other places, what they charge, what doctors charge, what hospitals charge. We charge much, much more than any other country in the world. And that means that we have this problem, which is that cost containment reduces revenue. And a lot of people don't like to have their income cut. But we have very high incomes in the United States for healthcare professionals and organizations compared to any other country in the world. So we are going to have to find ways, and I think that prepayment is one, ways to reduce or preserve incomes well enough so that the changes are tolerable by reducing waste in the use of services. And that requires innovation in the way care is organized and delivered. That involves what I would call microsystem change and the rapid and widespread dissemination of those microsystem improvements, which I think are possible. Computerized decision support has enormous potential in this regard, but there's no incentive to use it right now, so it doesn't sell. So I would say that the hope is in changing the incentives, stimulating innovation, reducing waste at the front lines by engagement of providers in reducing waste, and engaging them by convincing them that the only way to preserve their income is to reduce the waste in the healthcare system. And that, I think, is the dynamic that will play out. By the way, the Affordable Care Act, which expanded health insurance to 20-some million people, did not cause the cost of healthcare to go up.
Okay. Thank you.
Another question up there? Yep, thanks.
I'm actually going to move a little out of this.
Oh, that's much better. Thank you.
I can't see anything, so can I take this out? Okay. So I'm Selena, and I work with Mount Sinai Innovation Partners. I had a question about stigma. So we talk a lot about money and how money is driving a lot of these decisions, but to what extent does stigma, for example, people with cerebral palsy or Down syndrome, and the ideas that society has about those people, or the medical world in general, I guess, how does that also play into this, if at all, and what can we do about it?
Because I was going to point to either John or Angela, who have done a lot of work with vulnerable populations, and see if you guys wanted to tackle that one.
I can tackle some of the questions there. I mean, obviously, adolescents can be facing a lot of stigma, and in our clinic, we have youth of color, we have men, women, we have transgender individuals, we have LGBT individuals, we have youth with physical disabilities, we have youth without much means, so lower SES. So there's a lot of stigmatizing conditions, and I think we spend a lot of time talking to the youth, and particularly with my programs that I am most directly involved with, the transgender health program and also the HIV positive program and the HIV at risk program, so the PrEP program that we have. We do talk to the youth a lot about how we engage them. We renovated our intake forms 6 months ago, and we're still revising it to better get at things like, what is your preferred name, then we got rid of that term. We now use name in use versus birth name. What is your gender that you identify with, and then what are the pronouns that you prefer? And this has gone over really well because we can sort of help be respectful to the kids and use the name and the gender that they use. We've had a number of LGBT parents, and so one of them pointed out that you can't really say, on the intake sheet, who's your contact, mother, who's your contact father. Not every family has a mother and a father. So we changed that to parent one, parent two. So I think a lot of what we've tried to do is talk to the kids in our population and ask them about stigma and ask them what are the things that we can do to make their experience better. I don't know if, Angela, you want to add to...
I just wanted to say that even how you name your programs can address that. Like if you call mental health clinic and family planning clinic and HIV clinic and substance abuse clinic, we know that there's a stigma out there. So we call our program a center, a youth center. So that's one thing. Also, like the fact that we integrated, we have a pretty large mental health program with child and adolescent psychiatrists, psychologists, social workers, and people often say, especially people of color, they don't believe in mental health. If they will not go, they will think that you're saying that they are crazy. But what we do, One is the way that we actually design how the young people get those services themselves. I'm a medical person. I see my young person. I know that they can benefit from this mental health. So I just say, you know, I have a colleague. We work together. And that's either the psychiatrist or the psychologist or the social worker. And it's a really warm connection. I don't have to say to them necessarily, I'm going to refer you to mental health. But I say we are a team, we will work together. And we have thousands of young people of color receiving mental health on a weekly basis. So it's also thinking about, you know, culturally, how do you design things? How do you make it easy for people? Not just be with these rigid designs that may not work. And addressing and also helping people understand the stigma out there and perhaps how to address it, help them with a sense of self. So, you know, it's complex, but there are different ways to try to address it and ameliorate the impact.
Well, so I was wondering, Dr. Blumenthal, you talked about culture and changing the culture and like having doctors focus less on individual success and rather like working in a team. So to what extent, like, would you say that the attitudes about people who have cognitive or physical disabilities is also part of that culture and how it can be maybe changed or how it already is being changed?
Well, there are people in this panel much more able to address that than I. I do believe that among physicians and other clinicians that there are cultural biases. We are all part of our society. We struggle, I think, to overcome them. There's a lot of good evidence on racial bias among clinicians. It's highly prevalent, not acknowledged, not often consciously felt, but present. And there is more attention now to diversity, equity, inclusion in healthcare settings, so that's a start, but it will be a long journey, I believe, to get to where we want to be appropriately stigma-free or bias-free. But it's something that every organization has a responsibility to work on. It is very hard to incentivize that through public policy. These deep cultural and quite frankly human tendencies to see people who are different as other than us, and we are going through a huge national experiment with that process right now. That is a very, very deeply human instinct, and I think it is a long, long, long journey to rid us of it in medicine and in other areas of life.
Thanks, David. That was, I think, better said than anybody else could have said on the panel, so thank you.
Thank you.
Can I have another question?
One quick question, because I have one I have to ask in the last 10 minutes, because I want to know the answer to it.
Okay.
Go ahead.
So one last question. So my interest is about the impact of ancestry on diseases in the US. But before I started to focus on ancestry, I was looking on some risk factors around the US, and it seems to be that in the south of the US, in the deep red states, I don't know how you call it, there are some policies that might impact more African Americans in these areas. So, for example, for people of color, we know that there are high level of HIV infections and other kind of diseases, but the screening or PrEP is not provided for this in these states, but it somehow put in risk more people of color, African American in this case. So how can we deal with this? So, for example, it's a politic decision. It's not really, we know what to do, but we cannot really do anything because the politics in these states is different than, let's say, New York City or Massachusetts. Thank you.
I mean, I think the short answer is vote. Get out and vote. Because some of these policies won't change until people make their voices heard. And that's true.
But it's not so easy for
I didn't say it was easy.
In the South, I don't know, like they seems to be that they have like policies which even like recently we just heard that some of the votes of the people were from specific areas are not allowed. So the Supreme Court supported actually.
I'm going to take my privilege because I think we could spend a lot of time discussing disparities in the U.S. healthcare system and the U.S. healthcare and the U.S. in general, and I'm not sure we're going to come to an answer very quickly, except to recognize that it exists and it is a major barrier to healthcare for many Americans, unless somebody really wants to tackle it. No, I'm seeing a lot of shaking heads. So I actually have a question that's been bothering me a lot, and I'm going to take advantage of the experts on this panel who've done research in this area. Dr. Blumenthal brought it up in his discussion, which was great, and it sort of filtered throughout the panel discussion. And what my question is this. We know, based upon research here, based upon research in other institutions, that the key determinants of access to and quality of health care are things such as access to transportation, caregiver ability, health literacy, things like access to fruits and vegetables in your community. And these are just some of the social determinants that impact healthcare. And we know from Betsy Bradley's work, Vassar's gain is health services, research is loss, that possibly part of the explanation, or there are correlations, are around nation spending around social programs versus healthcare. And we, for good, bad, or indifferent in this country, have decided to put a lot of those resources into healthcare rather than in social services. And I have heard from many that because of that, institutions like Mount Sinai and others have a responsibility not only to provide health care for their population, but address the social determinants within the neighborhoods which they're sitting. Now, that may not be explicit, but under risk-based or value-based care, it is certainly implicit, because without addressing those factors, it's very hard to control costs. So my question to all of you is, one, to what extent are our healthcare, and I use that as healthcare rather than medical care, institutions responsible for addressing the social determinants in their community? And if they are responsible, what approaches should we be taking to doing that? And if they're not, what are the policy changes we need? And I would just love to go down the panel and hear people's thoughts. This is a dinner time conversation, by the way, between my wife and I, and we are on different sides of this. Angela, do you want to start?
We have an expert.
Oh, yeah, all right. I love how you pass the buck.
Yeah, that's good.
Kelly?
I'm going to speak about this very issue, but it depends if we consider ourselves producers of health or producers of health care. And if in pediatrics, I believe the field is committed to the health of children, and therefore these are the primary determinants of health, not health care. And so I think the obligation is clear. I think there are many, many tools that are not utilized.
I've thought a lot about this and reluctantly come to the conclusion that the beginning of the solution to our widespread deprivation is in the hands of healthcare organizations. That's not my preferred solution, but if you're practical, you realize that we've got this huge Fort Knox of excessive resources in the bank accounts and reserves of healthcare organizations, and we're continuing to add to it. And if we can create a system where it becomes in the interests of those organizations to do whatever they can to ameliorate the health undermining conditions in their environments, immediate environments, we will do some good. It's not a comprehensive or final solution, but it's the first step. So, and I don't expect any healthcare organization to do it out of altruism. I think it has to be, that's why we have an ROI calculator on our playbook. We have to convince chief financial officers that they have to do it. Because if they don't do it, they won't meet their margins, the target margins. So I think of it as a very practical thing. You know, it's not the final solution, but it's a beginning.
John, thoughts?
I guess I'm a little ambivalent because I do try to be as holistic as I can and spread my knowledge as far as I can with, you know, things like talks to parent groups or talks to youth or all sorts of other things, talking to the media about what I do. But I'm, you know, also of the other mind that there are things like, you know, people spending money to put clinics inside of high schools so that the kids don't have to be taken out of school for health care. And I wonder if you improved the regular health care that they had, would the Department of Health or the city government then have to, could they then take those dollars and put them into things like education, like other social support? So I guess I'm a little ambivalent about the extent that I feel like my reach should, as a physician, should go.
Liz?
So I largely agree that we have a responsibility for the health and wellness of our patients and, for me, of women. And so I do think that social determinants of health are an important target for us to think about in terms of health care. But I'm just going to take you on one small example. When you think about maternal deaths and the excess deaths in this country, it's been documented now through CDC that 60% of them are preventable, and that and many of these severe complications are preventable. And it's through our failure in quality of care that some of these events are happening. So I want to say that while I really strongly do believe that we have to address social determinants, in my own area of research right now, I feel like I have to keep pushing and talking about, you know, just standard care practices, you know, communication skills, some of the basic things around quality of care in our hospitals where women deliver is really, really important. And so we can't lose sight that we have that responsibility. And so I think you have to really think about the area that you're targeting and what you're thinking about, and make sure that you have the correct balance.
So the theme of these 2 days is, right, Sinai innovations. And so I think a question is, as we think about how we're each creating innovative models of healthcare, I mean, I completely agree with Liz. I mean, I think we do have a responsibility. The question for these 2 days is, how do we build that responsibility into the work that we're doing to move our fields forward? And so and we talked a little bit about research funding before, but the real challenge here is, I can't write an R01 grant, which is the backbone of academic medicine, and have the aim, number one, be to empower patients and families to better access healthcare, right? I mean, as a reviewer who reviews grants, that would get blown out of the water, right? So how do we sneak these things into our programs as we're building them, choosing how to get it funded, to think about how we can, at the same time, build innovative programs that show very concrete results while at the same time building in this question. And so I keep referring to our community health workers, which I think are a great example of folks who are on the front lines, empowering patients and caregivers on how to access the system and teaching them how to access a healthcare system, which is something we'll never be able to measure, but ultimately is the backbone on which the more standard outcomes we're going to be looking for will lead to the improvement in those outcomes.
Nina, you get the last word.
So I really hope that your idea about the R01 is not going to work, because I just put one in to deal with financial toxicity and improving access, because one of the issues in terms of the work that I spend much of my time in cancer has to do with getting access and improving quality. And one of the biggest problems that our community members brought up was this whole challenge, and how do we reduce financial strain to enable that kind of access. So, but getting to the whole issue in terms of social determinants of health, I do think that academic medical centers in particular are often in areas of vulnerable populations in need, and we do have a particular responsibility for our community and our catchment area. That being said, I don't think that the healthcare institutions, while responsible for health, can really tackle all of the social problems that end up causing increasing health issues for the communities that we do serve. So that being said, I think getting back to what David was talking about, just in terms of the framework, we are clearly responsible for the microsystems and doing everything that we can to improve the quality and ensure that we actually provide the same quality for all patients who come in the door, regardless of things that may cause stigma, regardless of socioeconomic status, regardless of race, ethnicity, regardless of LGBTQ. Everybody who comes in here should really be getting the top level of quality. That being said, there also need to be ways to deal with some of the major underlying social challenges that are unequally distributed in the populations that we serve. And so part of what I spend my research doing, and what I think is important to weave into the innovative programs, is really partnering with community organizations and individuals to be able to supplant the resources that are missing and start building up some of the areas that are really problematic and causing or contributing to the worsening health. That being said, vote.
So I've got oh, it's now green. I had a big red flashing number in front of me that said stop. So I'm going to stop. I really want to thank our panelists. It's really been a thrill to have all of you here. We were thinking about who could be the dream team and then how to get them. We came up with the dream team, and it was easy. Angela just said, could you join us? And that was done. David, thank you really for a spectacular talk to lead us going. And Kelly, we're really looking forward to your talk coming up and the solution or the answer to my question. Thank you.